This particular session I've personally been looking forward to for months, really, because it really speaks to challenges that every single one of our communities has faced. It speaks to a systemic shortcoming in the life sciences, and the hard data is not in anyone's favor when the 2018 list of FDA-approved rare disease drugs had clinical trial participants ranging from 0 to 4% in the African American community and in the single digits from the Latino community. And we all know that we can do much better than that. Science requires it. Good therapies require that. And from there, we can start to actually, there are elements now in place that we really should be starting to focus much more on our inclusion strategies and having diversity be a strategic aim in our data. So with that, I'd like to kick off this panel with an esteemed panel of speakers here. So joining us right now is Liz Horn, PhD, MBI, Principal at LHC Biosolutions, who will be leading our final panel, which sets us on our path for this next decade, where we go beyond rare disease awareness and focus on inclusion and diversity for increased value and investment as well in rare diseases. Liz builds research initiatives with nonprofits focusing on registries and biobanks with experience in autoimmune, rare, and infectious diseases. She's mentored and trained more than 75 advocacy organizations in the translational research enterprise and holds a PhD in molecular pharmacology and cancer therapeutics from the University of Buffalo and an MBI from Oregon Health and Science University. Joining Liz are Linda Wade, CEO, President, co-founder of Sickle Cell Association of Texas, Mark Thomas Foundation, former U.S. Health and Human Services Patient Advocate Advisor on the Blood Safety and Availability Committee in Washington, D.C. She was appointed under the Bush administration and served one term under President Obama's administration on the Genetics Regional Mountain States Collaborative. Jordan Shumway, LMSW, Sickle Cell Association of Texas, Mark Thomas Foundation. She fosters close relationships with clients and uses her science background to generate data for the agency. And she holds a BS in biochemistry from the University of North Texas and an MSW from University of Texas at Arlington. Crystal Davis, founder and president of Texas Rare Alliance and Texas Newborn Screening Advisory Committee member. In May 2016, Crystal advocated it alongside the FAST movement, which is Families for the Acceleration of Spinal Muscular Atrophy treatments, in a meeting with top FDA representatives for access to Spinraza and SMA treatment in clinical trials at the time. Today, Crystal advocates for whole genome sequencing for newborns, expansion of newborn screening programs, insurance policies that conform to FDA labels for orphan drugs, and clinical trials and real-world evidence, and holds a JD from Stetson University College of Law. And finally, Robin Carrell-Carlisle, MPH, a CHWI public health consultant and community health worker instructor from here in Houston. Robin began her career over a decade ago as a Peace Corps volunteer in rural Peru. She worked alongside local authorities to train and empower community members to be health advocates and educators. She joined Dia de la Mujer Latina as an instructor in 2013. So I'd like to kick it off now to Liz. I'll hand over the clicker to you.
Just come get it. Thank you so much, Christian. And I'm so excited about this panel because, as you said, this is an area where we all need to do better, and what we're doing just isn't sufficient. And we have a wonderful group of really talented and experienced ladies that are doing wonderful and amazing things in this area. So what we're going to do is, this is going to be different than what I told you since Christian introduced all of us. I'm just going to hand the clicker over to Linda, and she's going to start. Linda and Jordan are going to tell us about their experiences with sickle cell and how they're building a more inclusive research program.
Well, again, I'm Linda Thomas Wade, and I am the president and co-founder of the Sickle Cell Association of Texas, the Mark Thomas Foundation. We started as a grassroots organization. It was just my husband and myself in a 2-bedroom apartment. I would like to say how I first found out about sickle cell disease. I'm originally from Oakland, California. And one day I was walking through the mall, and as some of you may know, the Black Panthers originated from Oakland, California. And I was walking through the mall, and they were doing a health fair. And one of the Panthers called me over and said, "Hey, sister, let me tell you about a disease." I had never heard about sickle cell disease. He said, "Let me test you." Well, I looked at him, he was cute, and I went over and got tested. But little did I know and realize that 2.5 years later, I would meet a wonderful man. And on our first date, he asked me if I had sickle cell trait. And I said, "No, why are you asking me that?" He said, "Because I'm going to marry you." And we were married for 27 years before he passed away due to complications of sickle cell disease. And that was the late, great Pastor Mark Thomas, who, even though he suffered from sickle cell disease, pulmonary hypertension, congestive heart failure, and he was on oxygen 24 hours a day, he never stopped advocating for families living with sickle cell disease. And unfortunately, he passed away at the age of 46. However, his legacy and his mission continues to this day. Sickle cell disease is a life-threatening hereditary blood disease that affects the red blood cells. The CDC reports that sickle cell disease occurs in approximately 1 of every 365 African American births and 1 in every 16,300 Hispanic American births. And approximately 100,000 Americans are affected. We have a very high Hispanic population here in Texas living with sickle cell disease. I would also like to say we have 4 Caucasians living with sickle cell disease. And as you can see, one of our beautiful kids, blonde hair and blue eyes. Some of our accomplishments: we have successfully assisted and lobbied for legislation in Texas to begin testing of all newborns for sickle cell trait, regardless of race. We have 2 board members who have served on the Texas Sickle Cell Advisory Committee, and 2 are on the Sickle Cell Task Force currently. I have had the pleasure of meeting with former President Bush to discuss sickle cell issues. And as we heard earlier, that I was appointed under the Bush administration as a United States Health and Human Services Advisor on blood safety and availability. We also were the only sickle cell organization in the country to receive an exclusive White House Oval Office invitation to meet with President Barack Obama to discuss sickle cell disease issues in his first 100 days in office. And sometimes when I present, ladies will pull me to the side and they'll say, "Is President Obama as handsome in person as he is on TV?" So ladies, yes, he is. Now, we are going to talk about sickle cell and our client demographics. We do have some wonderful social workers, and one of them that is accompanying me today is Jordan. So I'll hand it over to her.
Thank you, Ms. Wade. My name is Jordan, and I'm one of the 5 social workers that currently work with the Sickle Cell Association of Texas Mark Thomas Foundation. And I really wanted to talk to you guys today about how there's kind of 2 types of data that we try to get with our clients. And the first is kind of the baseline data. It is our demographic data. And you can see here that we have a couple examples of how we've used our demographic data. This is the type of data that we use to understand what types of services our clients need. And so some examples are, you can see on the left side that most of our clients are in Houston, but we have large populations in San Antonio and Austin as well. But we started having more and more clients coming into our agency in the Dallas area. And we realized that there was nothing in Dallas to help these people who were suffering from this debilitating disease. And so we are in the process of opening our 4th office location in Dallas. We are planning our first event for next month. We're very excited about it. And then another example is on the right, you can see we have the distribution of the ages of our clients. And one of the things that we noticed several years ago was that in people who are aged 15 to 20, who are transitioning from pediatric to adult care, there is very little for these patients. And I'm sure that many of you can relate to that. Pediatric care for sickle cell disease tends to be pretty great, but then these patients age out and they become young adults, and there's nothing to help them navigate the system and the changes that come with that. So we started a camp called our Camp Next Level, where we invite patients who are in that age range to come and learn about transitional issues, how to advocate for themselves, how to take care of themselves medically, just as a way to kind of educate them as they move forward to that transition. The other type of data that we collect is very focused on the patient themselves, because as we all know in this room, the reason that we do this is for our families. Our families and our clients are the #1 reason that we're all here. And the mission statement of our agency is to enhance and improve the quality of life for individuals and families affected by sickle cell disease and trait through case management, programming, and services. And I really want to focus on one portion there that is individuals and families.
That's right.
As we all know, when a person is born with one of the diseases that we are here to discuss, that it's not just affecting them. It affects their parents, it affects their siblings, it affects their grandparents, it affects future spouses and children that they may have if they're able to. It's a huge variety of people who are affected by these diseases. And so we don't just treat the client. When we have a patient that comes into our agency, yes, we look at them and we look at what do they need, how can we help them, but we look at the entire family. How can we help their parents? How can we help their siblings who are also on this daily journey with our clients? And as I said in the mission statement, there's 3 kind of main areas that we look at. The first is case management. As I said earlier, we have 5 social workers at our agency, and we are certified case managers. And we do a lot of case management for our clients. One of the examples of case management is I'm currently working with a little girl who just recently moved to Texas from Denver. And while she was living in Denver, she got braces because, you know, little kids need braces. And now she's in Texas and she's on Medicaid. And Texas Medicaid says, well, Colorado Medicaid put those braces on, so they need to take them off. How is she supposed to go back to Denver to get her braces off? So I'm working with her with Medicaid, doing case management, trying to help her get her braces off here in Texas. When it comes to programming, we do, you know, like I was saying, our educational camp, but we also have a camp for adults and we have a camp for the younger kids. So we have specific programming for every age group. And then with services, a couple examples of some of the other work that our other social workers are doing. One of our wonderful social workers that's here in Houston, she's here right now.
Yes, she is.
She recently had a client who was affected by the explosion that occurred a couple weeks ago in Houston.
Wow.
His house was affected, and while they're still able to be in their house, thankfully, this client is suffering from severe PTSD from being in this situation. And so she's currently working with him, helping him to get the mental health services that he needs following this terrible situation. And then on the advocacy side, one of our social workers that works with me in Austin recently had a 19-year-old patient who went into the hospital because he was having what we call a pain crisis in sickle cell disease. And the hospital that he went to gave him medication, said, you know, we'll take care of you, but they weren't looking at what was happening with him, and he was getting worse. And so our wonderful social worker helped him and his family to get him out of that hospital and take him to another hospital where he was diagnosed with pneumonia. And this kid most likely would have passed away if she had not advocated for him to get to a hospital that would actually care for him and give him the support that he needed. And so working with our families, like I said, we have many case managers, social workers in our offices. We do also have community health workers who help support us. We are all hemoglobinopathy educators, and we're all HIPAA certified. We do have bilingual services because we do have a large Hispanic population. We have 4 offices, and we serve clients in 52 counties across the state of Texas. We have 750 clients that we help with a variety of services, some of which I just mentioned. But one of the things that we're really focusing on right now is the mental health aspect, because a lot of our clients, which I'm sure many of you can relate to, having these chronic debilitating diseases is not easy on your mental health. Your mental health and your physical health go together. And so we're working on providing the mental health services, using our social workers to give those mental health services that can be helpful to our families. And so in the second part of data that I was talking about, the patient-centered data, what we do is we do patient surveys. We talk to our patients and we find out, what do you need? What are the things, what is lacking for the services that you're receiving? How can we help you more? How can we improve our services? And so we use patient surveys to assess how they're doing and then also assess how our programming is helping them along the way. Okay, and so that is it for our portion. I don't know if you have any questions for us before we move on.
That is really fantastic. So I actually did have a question about data collection, and I think it's so important to survey the community that you serve to find out what they need and how you can help them. So how do you survey them? I mean, is it online? Is it an app? Is it a paper survey?
Yeah, so we do a variety. So we recently had an end of year survey that we sent out with our end of year newsletter and asked patients to fill out online. We also do paper surveys at the end or before and after most of our events to kind of see how they're feeling. Since they're there in person, we ask them the questions in person. So we use a variety. Whatever is most accessible in that moment is what we use.
That's really great. And then, there are a lot of barriers, and geography can be a barrier. And that's so interesting that you realized that you had a nucleus of people in Dallas, and then you needed to actually have services closer to them to meet their needs. So how did you identify this group in Dallas? Were they coming to your events in other communities, or?
I would like to say that we provide services wherever the families are. And so what was happening is we were getting calls from the Dallas area requesting services. It would be, maybe we would do a health fair or word of mouth, which is one way that the families communicate with. And they would reach out on social media. And so what we were doing, we had one of our wonderful social workers that was just driving up there and assisting. And then we thought, you know what? We need to be there. And I neglected to say earlier, our social workers are great, but we also have some wonderful staff that lives with sickle cell, that works directly with our families, and that are mentors. And so the trust factor is very important in the sickle cell space, as well as in rare diseases. So the families trust us.
That's so awesome. Thank you so much for sharing your story. And Crystal, we really want to hear what you're doing in rare disease and newborn screening.
Yeah, so again, I'm Crystal Davis, and the two things that I really hope to be known for is that I'm a rare disease mom, and I advocate for the greater rare disease community. Texas Rare Alliance is a very new organization, and we are working to improve access and health outcomes for Texas rare disease patients through education and advocacy. And it's important to note that access includes both access to the diagnosis and access to treatments. One way that we work to achieve this is by launching Texas Rare Alliance meetups, and we look to involve the stakeholders in the rare disease community in Texas at these meetups. And we'll hold these in the Dallas-Fort Worth area, Austin, San Antonio, and Houston. The meetup in Austin will be webcast, as will the Spanish meetup in Houston. Two of the topics for our early meetups will be the pathway to the diagnosis and the need for a Texas Rare Disease Caucus. We have many underserved populations in Texas, and these include patients who are minorities, patients who cannot effectively communicate in English, patients who live below the poverty line, patients without health insurance, and patients who live in medical deserts. Newborn screening is an effective tool to provide the diagnosis to underserved populations. And that's why in 2019, we really focused our advocacy efforts on improving the newborn screening program in Texas. Monica Weldon is here, and she was actually a great partner in that advocacy. And we achieved this through two ways. We advocated to secure newborn screening deficit funding and advocated to establish the newborn screening preservation account. And that allows the newborn screening program to retain the funding from the newborn screening kits so that it can swiftly implement new conditions as they are included on the recommended uniform screening panel. Newborn screening is the best opportunity to combat socioeconomic disparities and democratize the diagnosis. The time of birth is the one time in healthcare that we are on the most equitable footing. Once babies leave the hospital, socioeconomic disparities raise their heads and prevent many babies and children from obtaining a timely and accurate rare disease diagnosis. The Texas Newborn Screening Program screens 400,000 babies twice for 54 conditions. And this is important. We do that because we want to avoid false negatives wherever possible. We want to provide the opportunity for pre-symptomatic diagnosis and treatment, and that's the gold standard that we should strive to achieve. Newborn screening in Texas is an overwhelming success for the newborns with screened conditions, but there are more than 7,000 rare diseases. And what this means is we're not even screening for 1% of the rare diseases through newborn screening. And this is significant when it comes to the rare disease diagnosis in children. It takes on average of 5 to 7 years to obtain an accurate rare disease diagnosis. Sadly, many children with rare disease will not survive to see their 5th birthday. We cannot continue to allow the status quo to continue and allow babies and children to die without providing them an accurate rare disease diagnosis and treatment whenever possible. Today, there are more than 300 conditions that meet the criteria to qualify for the RUSP, except for they lack an approved genetic test. And what that means is if the doctor had that diagnosis, there would be medically actionable standard of cares and treatment to improve the health outcomes for those babies and children. This is why I support the implementation of Project Baby Dillo to follow the success of Project Baby Bear in California. And Project Baby Bear is a pilot study that provided rapid whole genome sequencing of NICU and PICU Medi-Cal patients. And it established proven health outcomes and proven economic benefits. For the 41 patients that participated in the study, there were 165 hospital days saved and over $1 million in healthcare spending. California Assembly member Marie Waldron said, "Rapid whole genome sequencing is faster, better, and cheaper than traditional treatments. It has led to vastly improved outcomes for the babies themselves, and it saved taxpayer dollars." When I read that, I hear win-win. We're improving the health outcomes in babies and children, and we're saving money. Project Baby Dillo would provide whole genome sequencing to NICU and PICU patients insured by Texas Medicaid with unknown etiologies. And what that means is They're in the NICU and PICU, but we don't know the underlying condition that is causing the symptoms. It will provide the ability to diagnose and treat many more of the 7,000 rare diseases. And at Texas Rare Alliance, we will provide caregiver experience and preference data on access to the diagnosis. And we'll do this through surveys and other mechanisms to ask the caregivers, when your child was admitted to the NICU and PICU, did you receive a diagnosis at that time? If not, how long did it take to obtain a diagnosis? And what did that process look like? And then going to the preference side, what is your preference to the diagnosis if you could go back and do it again? Would you want to know at the time of birth? Would you want to know at the time of onset of symptoms? And this data is important to pair with the health economic data and the health outcome data from Project Baby Bear as we go to our senators, representatives, and their health policy staff to advocate for Project Baby Dillo. And Project Baby Dillo, Project Baby Bear, and other Project Baby data can be used to justify the implementation of newborn whole genome sequencing in the future. The next steps for Project Baby Dillo are to recruit advocacy partners to join the Project Baby Dillo task force, recruit hospitals to participate in Project Baby Dillo, identify a partner to perform the whole genome sequencing, and conduct the caregiver surveys to obtain the patient experience data and the patient preference data on access to the diagnosis. Hold advocacy events to educate members of the rare disease community, healthcare providers, representatives, senators, and their health policy staff. And we need sponsors for the bills in the Texas House and Senate that will provide funding for Project Baby Dillo. Project Baby Dillo is personal to me. This picture is our son Hunter the day that he was born. Hunter was born and he experienced respiratory failure and was quickly whisked away to the NICU. He's intubated. He remained in the NICU for 11 days and was discharged without a diagnosis. Because the doctors didn't have a diagnosis, they weren't able to follow the appropriate standard of care, and Hunter's condition deteriorated while he was in the NICU. Hunter was ultimately diagnosed with spinal muscular atrophy type 1, the leading genetic cause of death in infants. SMA now has approved treatments. We have the technology to do better in providing diagnoses to critically ill babies and children. Now we have to roll up our sleeves and do the hard work to make sure that we can see the implementation of Project Baby Dillo so the doctors can receive those diagnoses. We have to provide these diagnoses. We cannot treat what we do not diagnose. Thank you.
That was wonderful. So I do have a question for you, because this had to be such a scary, scary experience, a really exciting next chapter of your life, a really big unknown, lots of doctors, white coats, tubes, very scary. So how, when you're working with Project Baby Dillo and other caregivers and families, how do you build trust with them during this time that is so unexpected and so stressful, and especially given all of the underserved communities in Texas? It seems like a really big undertaking.
Yeah, so those of us that has gone through the situation, we have the ability to demonstrate empathy and compassion, and that goes a long way. But we have to go to those patients where they are. And many times that means partnering with others. Because if we don't understand the cultural barriers, if we can't communicate effectively, then we're going to fail. So we have to figure out how to establish the collaborations that we need to provide that health equity.
Yeah, absolutely. And then having shared experiences and not just being like, oh, here's a piece of paper, figure it out, which we heard from earlier, which sounds so scary. So how old's Hunter now?
Hunter is now 8, and he's doing very well. He has had the benefit of being on treatment since he was 8 weeks old.
And the diagnosis was really important to be able to make that happen.
Without the diagnosis, we couldn't have taken the action to help save Hunter's life.
And this is a really good segue to Robin.
Thank you. And may I just say, I'm just really honored to be here. The stories that I'm hearing from you all and that the stories that are in this room, I think are just really inspiring. So thank you for having me. I'm really excited to talk with you all about our organization, which is Diario de Mujer Latina, or DML. So DML is, like many of the organizations represented in this room, it's a grassroots, community-based organization, and it starts with a story. So our founder, many of you might know her name is Venus Henez, and prior to working in this space, she was actually a flight attendant. And she was on a flight and slipped and fell and had to get emergency medical attention. And while she was in the ER, the doctor asked her just very casually, have you had a mammogram recently? And she looked at him and she said, no, I'm a Latina. Latinas don't get breast cancer. And the doctor explained to her very kindly, well, no, Latinas can get breast cancer, and if you'd like, I can do a breast exam while you're here today. And he did, and he found a lump. Sorry, I get so emotional because I love Venus. She's amazing. So Venus was diagnosed with breast cancer, and as she was going through this experience, she was trying to educate herself on breast cancer, especially as it affected her community, the Latino community. And she started seeing that there wasn't a lot of information. There wasn't a lot of statistics out there about cancer in the Latino population, especially breast cancer. There wasn't a lot of information that was written in a way that was culturally relevant for her. And through this experience, through her experience with breast cancer, she noticed that there were whole groups out there, whole populations that were being left out of the loop. They weren't being brought into the fold. They weren't being brought into the conversations. And so she founded DML. And their very first event was she partnered with the Mexican consulate to host a really kind of revolutionary, culturally relevant health fair. Something that provided information in a way that really spoke to the population that they were trying to serve. And from there, it just really, it bloomed. And she's expanded in so many different ways. DML has now touched 39 different cities. We've done projects all over the United States, all over Texas, of course, but also in Mexico and Puerto Rico and the Dominican Republic. And really the cornerstone of DML's mission is community health workers. We train community health workers and promotores in a wide range of skills. And what we do is we teach a toolbox, and that toolbox can be applied in so many different ways and in so many different areas of health. And for those of you who are unfamiliar with what community health workers do, they are on the front lines of public health. They are typically individuals who are trusted members of the community, either because they are members of that community, they grew up there, they have family there, they live, they work, they pray in that community, or because they have an unusually deep understanding of that community. And we train those individuals with this toolbox to be expert listeners, to be expert educators, to be expert data collectors. A lot of the data they collect, it's not with structured clinical protocols, with nice charts and graphs. A lot of the data they collect is just listening to the people in their community. They're talking to people at church on Sunday. They're talking to them at daycare. They're in the communities every day, working and living, and through that, they're able to collect all of this information that's very important. And then they serve as a bridge to the public health and medical communities. So as an example, a few years ago, many of y'all might remember that Zika was an international concern that was raising alarms, especially here in Texas. Zika is a virus, many of you know, that is spread via mosquitoes, and if pregnant women are infected, it can cause challenges with growing babies, and it can cause birth defects. And so it was primarily affecting Latino women. But a lot of Latino women, as we found through our community health workers, didn't know a lot about Zika. They didn't know how to protect themselves. There was a lot of misinformation. There were a lot of myths. There were a lot of fears. And so we trained community health workers to understand, what are the signs of Zika? What should you look for? How can people protect themselves? And then the community health workers went out. Oh, sorry. The community health, can you guys all hear me? I'm so sorry, I've been talking this whole time. The community health workers went out and then told that information to their communities. But in addition to educating that community, educating the Latino populations here in Texas, they also listened. They listened to what were the common concerns, what was the misinformation, and what were the needs. And then they gave that information back to the public health community, back to the medical community, so that there was a dialogue. So community health workers are a really important bridge, especially to underserved and underrepresented populations. So something that we're, I was pushing the wrong button. Embarrassing. So they, like I said, that this is a toolbox that we're training them to use. How community health workers use it in a wide variety of ways. They host health fairs. They help individuals personally navigate medical systems. They sit with people in a doctor's office and they help that patient understand what's going on. They understand the issues of health literacy, of cultural competency. They advocate for individual patients. They also work in schools. They work in community health centers. And one thing that we're really, really excited about is that we're going to be very soon, we just got funding and we're starting the process now of training community health workers to be clinical trial navigators. So as been mentioned many times today, there are gaps in our clinical trial research where there are populations that are just not being represented. And so what we are hoping to do is we're going to be developing a curriculum to train community health workers with the toolbox they already have, the trust they already have in their communities, to work with researchers to recruit individuals to participate, a diverse population of individuals to participate in their clinical trials, but also retain those populations. And that takes a lot. It takes helping these community health workers work with researchers to understand the importance of diversity in their staff, understanding the importance of culture as it relates to health. I think many of you all know health is not a waffle. You can't just pour syrup in one square and expect it to stay there. As Jordan mentioned, mental health affects a lot of individuals with chronic disease. There's a lot of comorbidities and a lot of different ranges. Health is a lot more like spaghetti. You put sauce on one noodle, it might get on other noodles, right? And so what community health workers can do is they can help researchers understand those cultural differences, help them create protocols and policies that can adapt to a multicultural patient population or research population. And then, what we really hope to do is help expand that all across the country, working with researchers all across the country to make their clinical trials a lot more diverse and representative of the populations that hopefully can use this information. And with that, if you have any further questions about these programs, please feel free to reach out.
That was fantastic. So yes, let's give the panel a round of applause. So I actually had a question about the clinical trial navigators, and especially in other languages in the Hispanic community. Have you worked at all with IRBs to work to get the consent forms culturally competent? Because well, you go first.
Oh, no, so we haven't yet, but that is definitely on our radar. Because a big thing that we've noticed at Data Mujer Latino, we work with a wide variety of populations, but the Latino population is obviously at the heart of Venus's mission. And it's not just about translating.
Exactly.
It's very frustrating because a lot of organizations, and they might not know, they might not realize that it's not enough to translate something into a different language.
Right.
There are so many for example, we're working on a big project right now with mental health first aid. And mental health first aid is a really important aspect to think about cultural diversity, because mental health is such a deeply personal and deeply cultural thing, not just in terms of recognizing signs and symptoms, but also getting treatment and stigmas associated with that. And so in some of the materials that we're using, some of the materials were very clearly just translated. And it's very useful to have it in a different language, but if you're not also translating the scenarios, the examples to be culturally relevant so that it really resonates with people, that's really important. And so in addition to translation and looking at cultural competency, you also have to look at the issue of health literacy and what words are you using. So I as was mentioned in my bio, I worked in Peru. There actually aren't a ton of Peruvians in Houston. And so the Spanish that I use is actually kind of funny. I learned Spanish in rural Peru. So I use different words that sound very funny to my Mexican American colleagues. And so that's important for me to know my own limitations with Spanish, that even though I speak Spanish, I might not necessarily be using the words that resonate with the population that I'm serving. And so a very long way to say, we're very excited to work on it, because I think that's an undervalued aspect of the IRB process.
Yeah, and I think that's something that even could be done at a higher level, whether that's something Global Genes or another organization wants to take on, because a lot of the IRBs, they require to use the translation service. So you want to make sure that you're getting a broader community, and it's not just people that only speak English. So you're like, yay, my consent form is translated into Spanish, but then when you have the people that are doing the consent, they're like, this is kind of ridiculous what it says, and it's like, so I think it's a bigger systemic issue. And I did have a question for the whole panel before Pam does the polling question. So we're talking a lot about some really rich structures where we're using navigators and training and social workers. What can we do if we don't have that infrastructure? There are groups that are smaller, there are people that maybe you're just one person, maybe you're an investigator that realizes, hey, I've been really limited in the group I've been reaching out to, how do I do better? So what advice would you give to individuals, smaller groups? And this is for anyone who wants to take it.
Well, okay, I guess I get it.
Thanks, Linda.
Well, starting out as a grassroots organization, myself, as I mentioned, myself and my late husband, who was on oxygen, and we just took one individual at a time, one location at a time, whether it was the hospitals, schools, co-workers, neighbors. And then what happens is you start building a rapport, and then you'll have someone to come along and say, you know what, I'd like to help, or what can I do to help? And that's the way that, for us, it began to grow. And so I just want to say, if you are an individual group, don't get discouraged, be persistent, be diligent, and definitely continue on in the passion that you have, and it will catch on. And now you have social media. That was something we didn't have, back then, which is a great tool as well.
If I could add to that too, if you all ever have an opportunity to work with community health workers, I think they're a really great resource that's underutilized in general, but especially in the research space. And they can act as sort of key informants to help you kind of understand what populations are experiencing. They're trained in being expert listeners and communicators, and I think that they're a really valuable asset. And there are community health worker organizations all across the country, and just speaking from my own personal experience, they are some of the most passionate and caring people that you will encounter. They're very excited. I've yet to teach a class on some obscure thing where they weren't just really excited and eager to learn more so that they could share it with their community. So if you have an opportunity to do that, please do so.
And no, that's great, and I appreciate that. And I just want to say, I'm a certified community health worker in the state of Texas. Before there was even such a term, but then just thought I'd throw that in.
Crystal, did you think
and
that?
technology is great, but we also have to remember that in many of these rural populations, our patients will not have access
That is true.
to the technology. So we have to make sure in those cases we recognize that, we bring the technology to the patients, We in-service them on how to use it, and we provide the proper person on the other end to communicate them so they will be receptive to using the technology and continue to use the technology.
So when you say proper person, you mean someone that they're going to trust or that it's going to resonate because they're going to have a shared experience or there's going to be something
Yes.
that's going to make them want to work with them.
Telemedicine is great, but I think we're going to see a growing role played by telementoring.
I like that.
I love that. This may be a hard time of the day to have an open field for you to answer instead of multiple choice, but the question that we have is, what are some barriers that keep you from reaching more patients? So just in general, are there things that, we know that this is a real issue in rare diseases and would be such a benefit to be able to get more patients diagnosed and reach more patients. What do you out there in the audience or online think are some of your top barriers to reaching more patients and caregivers? Wow, there's a lot here.
Oh, can you use the mic? Yeah, sure. Yeah, thank you.
Sorry, my name is Robin Powers. I'm from Buffalo, New York. Currently, where I live, I go to get care at Roswell Park Comprehensive Care Hospital. And although they are a comprehensive center, I'm being told over and over again by every single department there that I need to go to a more comprehensive center. And they don't seem to understand that, although how much I tell them, there is no other center that will take my health insurance. They're the only ones that are a quote-unquote comprehensive center that will, and therefore my health insurance, even when I speak with them, I'm like, is there anything that I could do to possibly argue this in any way? Do you see this happening? They say no. And I'm just like, well, I don't know what to do, honestly.
So I don't know if that's something you can answer, or this is just one of the general challenges with the geographic nature of medical care and access to a center of excellence.
And how do you help people advocate at their centers for?
So one of the biggest challenges with sickle cell disease is that, unfortunately, there's a severe lack of healthcare providers who understand the disease. I could not tell you the number of times that I have spoken with a client or gotten a call from a client stating that, they are having a crisis or they're experiencing a problem and their doctors just don't understand. Going back to the example that I spoke of earlier with the young man who was in the hospital receiving quote-unquote care, but was not getting what he needed. And unfortunately, sometimes the only answer is, okay, well, let's take you somewhere else. And of course, in your situation, it's difficult because there is nowhere else. We kind of have an experience of that here because, Texas is a huge state. For those of you that aren't familiar, we are further away from El Paso than El Paso is from San Diego. So just to kind of put it in perspective. And Houston is the only place in the state of Texas that has a specific sickle cell comprehensive center. And we have clients that drive from Austin, from Dallas, from all over to come here because this is the only place that they feel like they get quality care. And that's, I'm grateful, and as I'm sure that they are, that it exists, but when you're talking about driving 4-6+ hours away just to get to somewhere where you can receive the care that you need, that's not feasible. And so that is kind of, I don't know that I'm really answering the question, but it's a problem, and we recognize that it is an issue. When you're dealing with these rare diseases, this isn't something you can walk into any hospital and get treated for. People don't know about them.
But would social workers maybe be a resource to help navigate the complex system for patients?
Yes, and we do that. We do navigate and try to connect our clients and people with the specific providers that are able to give them the best quality care. But also, as much as we do and want to do, we are limited by the healthcare system, unfortunately. And so whenever you're talking about a disease that people don't know about and that doctors don't know how to treat, we can't treat them as a doctor. You know, we can give them the information on where to go for the best care, but we can't do much more than that sometimes.
Yeah, and I think if anyone else has any ideas for Robin, catch her after this session, because I think this is something that a lot of people deal with. This isn't completely unusual.
Yeah, and it's so interesting to see all of the answers. Can you actually scroll those answers on the screen? Are there more that we're not seeing?
This is where I need
It's
my
all of
readers.
them. It'll just keep kind of switching around.
Okay, it's pretty amazing. Obviously, we have our work cut out for us as a community, and these are wonderful, wonderful insights that you've provided. I have a few questions, and I know it's getting kind of late, but
And
maybe
Pam, I've got 2 audience questions over here.
Okay. Let me just have one online, which is, are there rare alliance groups specific to individual states? If so, how do we find them?
Yeah, so they're relatively new. California Rare was the first, and Global Genes had Angela Ramirez, the founder, present in 2018. I attended, and I thought, wow, this is great. Somebody needs to do this in Texas. And just over a month later, I found out that we had great deficits that were constraining the newborn screening program in Texas. And I looked around, didn't see anyone, so that person was me. So there are new ones popping up all the time. And let's not end with the states. We need an Austin Rare, a Houston Rare, a Dallas Rare, an El Paso Rare, so that we can become connected as a rare disease community. And not just in Texas, we need to do that in the states throughout the US.
For political influence and for support and for other reasons, no doubt. Okay, thank you so much. I think we have a question over here, Hira.
Hi, everyone. My name is Sierra King. If we can all just come together, I think that honestly, we need a universal healthcare system. There are so many diseases and so many different type of just problems that go on with people mentally, physically, that we should be able to bridge this gap, and everyone, no matter what, regardless of where your health insurance or where you're from, especially if you have a pre-existing condition, you should be offered free health care. I just don't understand that, but I appreciate you for letting me speak. Thank you.
Yeah, thank you so much. And I see Christian coming this way. And I would just say we all have an important job in November, and that's to all go out and vote.
That's right.
No matter how you lean, that's your job. Go out and vote. Thank you.
I think Christian has a response.
Yeah, I mean, I'll hop up here, but basically, you're entirely right, and I think we've done a lot of self-reflection at Global Genes, and about what our role is. In the first 10 years, we spent a lot of that time helping drive awareness, give a platform for everybody. But at some point in your platform, Oprah Winfrey once said, once you have a platform, your platform has to also have a stand and take a stand for something. And so in this next decade, when we talk about inclusion and we talk about diversity, it's really about pulling stakeholders together. So we actually are in the works this year of planning a convening of everybody. The Research Alliance, which we're standing up this year, our Corporate Alliance, our Foundation Alliance, building basically a governing council specifically on this topic, including the regulatory space, because even the regulators, who may not necessarily be able to convene us because of their own rules, are happy to show up. So,
Christian, can I take one more audience question?
Yeah.
Sorry, it's not really a question, it's just a suggestion. Part of what you described very well is this inability to reach the doctors who are treating the patients, especially for sickle cell. And here in Houston, I think we have a very unique opportunity where you could talk with 3 of the medical schools who train most of the primary care doctors for the state of Texas. And so that's the medical school at A&M in College Station. That's the new one here at University of Houston, and then University of Texas Medical Branch in Galveston. And I know in Galveston, it's been a long time. It's been like 20 or 25 years. But when we were training medical students, they would come through the labs, and we would teach them how to do the sickle cell blood test, and they would actually run the test and have to learn about all of those things. And so maybe revisiting those local schools and talking with them about potential changes to the curriculum could really help you to ingrain the idea of these diseases in these young medical students, and then as they go out in the community, it could really help you reach those people.
Yeah,
Thank
something that we really need in the rare disease space is clinical care pathways. It's been very successful in the cancer space, and it requires the doctors to follow the standard of care and the treatments that they provide to be reimbursed. And so it's proven in the cancer space, and I think that we need to see it implemented in our rare disease communities as well.
Great, and I want to thank the panelists so much. I want to thank everyone for staying, and before I give the microphone back to Christian, I just want to plug a little bit the first 3 Data Do-It-Yourselves. They have some extra workbooks that are out there if you didn't get the hard copies, and they're beautiful and really nice to flip through and full of a lot of information. And I know we talked a bit about IRBs, and there's a lot of robust information in the second session, and I think that as we go through all of these, we really need to go back to the beginning because it kind of comes full circle and there will be a lot more learning for us. And maybe this is the beginning, it's not the end of Data Do-It-Yourself, it's the beginning of the next chapter.
Yeah, absolutely.
And
to your mouth,
didn't pay me to
from your
say
mouth to C's Ears and many others who are going to help us put this together and keep it going, honestly. Thank you, everybody. And truly, we ended with this panel because in some ways it's working backwards. It's getting to the core of what some of the greatest issues are, and we need to focus right here. So thank you. And closing remarks and what's next. So I'll grab. Yeah.
I meant that nice.
Yes. Thank you. One more hand. So a couple things as I kind of put my reflections together from the day and the series. My head and heart are full from having been able to meet all of you. Many of the people here, many of the people who've watched from online, who've attended other sessions. Really proud to say that today we had over 125 registrants and 119 are here, and that goes with pretty much the whole series. We've had 90+% attendance from those who registered, and really, really proud of you for making that kind of commitment. So thank you. Give yourselves a hand for that. I also want to give shout outs right now to 2 extraordinary people that I've gotten to know over the course of this program who have really, as I told them recently, this has been one of the high points of my entire working life, working with them, and that's Frida Hernandez and Pam Todd. Pam Todd, the extraordinary writer who put the workbook together. And also an incredible interviewer, and Frida Hernandez, who's been a right hand throughout, always kind of reflecting with me about the different ways we could run this program and kind of what to include, what content to follow what, and really understanding every step along the way what we needed to do. So thank you, Frida. So we have encouraged, at Global Genes, we stand for everything that we're talking about here. Encouraging collaboration, encouraging collaborative research networks. We do have more programs this year that kind of start to put this in motion in different ways. Before I get there, we'll talk about what's next. Any action is better than no action. And yes, I use a chutes and ladders board because that's the reality, right? I mean, we can throw every model at you, we can make it linear, we can make it circular, we can use chevrons, whatever, but the reality is wherever you are is a good place to be when you are making decisions and continuing on. So kudos for everybody who keeps fighting the good fight. Remember that as you embark on research projects, information has to be useful. Try to make the effort to collect it in a valid, shareable way and keep it maintained, keep the commitment. Play to your strengths as an organization. It's not just about making good use of the resources you have, it's also about finding your lane so that you can be a good partner and find other good partners who will do the same. Talk about your strengths with each other, talk about your weaknesses, find ways to work together. We've had great conversations very high up in the administration who are seeing this, and there's a long-term risk here that if we continue to build little data sets for every deletion and mutation and difference out there, we're going to set ourselves backwards if we don't find ways to work together and find ways to put that data to bigger use. And turn to your networks for help. We did lose just an incredible figure, public figure in Kobe Bryant. And without getting too reflective of a moment that might derail me, but he actually, one thing that he shared about his development in his career was that he had no fear of cold calling anybody who could be a mentor on anything. So I think that's a great piece of advice for everyone always. Have absolutely no fear of cold calling whoever you have to call to get a question answered. That includes anybody at Global Genes or any other organization that can help along the way. Keep looking for those resources and keep your cause going. So for us, next steps for Data DIY is to turn all this awesome programming, all of your feedback, your questions, the answers into self-guided education on rareuniversity.com. It'll be our next big series that we put there. Again, with generous support from CZI, from Chan Zuckerberg Initiative on that. And we'll also be translating the content to Spanish over the coming weeks. It's just a start. And also, there's a lot going on between now and our annual summit, including Rare on the Road. This is a series that's really a leadership training series that we do in partnership with Every Life Foundation. You may know them, they're Washington, D.C. based, but together we go out around the country and do kind of stops along the way that really bring in local community leaders to do some leadership training around advocacy, and these days, data-driven advocacy. A really good piece of advice we got from another prominent leader in Washington was, they love hearing our patients' stories, and yes, it's absolutely helping them define how they make their decisions, but the data that comes with it is where we are today. They've been hearing a lot of patient stories for years. Now they really want to see data. It helps them make cleaner decisions, and it depoliticizes decisions. So that's a big part of what we'll be doing at Rare on the Road. The Rare Drug Development Symposium. A lot of the content today, yes, it was dense. Yes, it was a lot. And yes, it's critically important to understand. The Rare Drug Development Symposium will go deeper into the science, provide scientific updates on different types of therapies, as David Spencer eloquently described this morning. So we really encourage your attendance there. And it's also a place to inspire young investigators and young scientists. It'll be co-hosted with the UPenn Orphan Disease Center. We're really proud of this series. It grows each year, and so we look forward to continued success there. If you haven't grabbed your copy of the next report, please get one here or download it. It's a compendium of what's going on in rare disease research, investment, policy, and patient trends, and it's a great roadmap and teaching tool for your communities and your leadership teams. It's loaded with insights from around the rare disease space, so really encourage you to grab your copy. Finally, stay current and keep up with us, and also submit ideas and people you think should be interviewed, people who are making a difference, people who bring kind of fresh perspectives to the rest of the rare disease world. The Rare Cast with Danny Levine is hosted out of San Francisco. He's incredibly well connected in the PR space. He's got a lot of access to a lot of kind of distribution channels. So it's a great resource for you to kind of not only listen, but pitch as well. And the Rare Daily is obviously it's a daily kind of blog and publication that we keep up with just breaking news from around the rare disease space, whether it's industry, new indications, new treatments along the way, or simply great stories from our advocacy circles. So, and finally, our big event is September 21st to the 23rd, our annual Patient Advocacy Summit. It'll be at the Sheraton in San Diego at the Marina Hotel. And we obviously want everyone there that make great use of it. Of course, it's loaded with content, several tracks from caregiver specific topics to breaking science, but most importantly also it's a great place to connect not only with other families and organizations in your specific area of research, but also a place to connect with geographically with people who might just be next door and you didn't even know it. And there's a lot of extra space there. I encourage people to think about how they can use their leadership team's availability to go cover a lot of it and also convene and talk about what to do next. So really hope to see everybody there. And before we sign off from our live stream, I'd just like to thank everyone in joining in person and at home. For me, it's been a true honor and a humbling journey to serve you, to work with this incredible team, to meet you and hear your stories, to connect you to each other, and to really have a path or a bridge built by us, for us, and for so many others that we represent. Thank you to the CZI team for your support throughout the series. Thank you to our mentors who continuously re-engage our learners. It's incredibly generous of you to be more than just speakers, but maintain availability, and we really appreciate it. Like everybody here, we all have our personal stories. I've seen personally in my own life the loss of a dear friend many years ago to a rare disease. Today, she would be benefiting from an available treatment that wasn't there then, and it was because a community came together and drove it. So I've lived the pre and post. I've seen personally, there's so many different journeys, and I'm kind of overwhelmed by it, but I'm so forever thankful for everybody here. So signing off from the live stream, and have a great evening.